Good evening. I'm Norman Armstrong.
And I'm Gloria Rawls.
Today we're discussing an article we read. The title is Tissue Plasminogen Activator Dose and Pulmonary Arterial Pressure Reduction in Catheter Directed Thrombolysis of Submassive Pulmonary Embolism. So, some background. Tissue plasminogen activator, TPA, is a thrombolytic agent that is used in patients with submassive pulmonary embolisms. Now, TPA is administered intravenously via a catheter in a process known as catheter directed thrombolysis, CDT. So, previous trials have been done to determine the appropriate dose and frequency of CDT, and they have all shown that administration of TPA in amounts greater than 2 milligrams per hour will result in a higher incidence of major bleeding. So this study was conducted to assess the incremental effect of TPA dose on artery pressure and bleeding during CDT of submassive pulmonary embolism. So the authors of this study, most of them are educators at universities throughout the country. The study was funded by the National Center for Advancing Translational Sciences, the National Institutes of Health grants. The authors also say, and they declared, they have no competing interests, and no competing interests exist. So this study investigated the hypothesis that CDT with a dose less than 1 milligram per hour extended beyond the normal 24-hour time period, so maybe to 48 hours. And the authors believe that extending it, as long as the dose is below 1 milligram per hour, will further reduce pulmonary arterial pressure without complicating bleeding events. So, this study included 17 patients whom have been previously included in the trial in order to provide new information and changes with pulmonary arterial pressure, PAP, during CDT. Two of the 17 patients were excluded from this study because they met the American Heart Association criteria for massive pulmonary embolism. And remember, this study was just specifically focused on submassive pulmonary embolism. Medical records and imaging of about 46 patients, 25 men, 21 women, who underwent CDT for submassive pulmonary embolism between September 2009 and February 2017 were examined. All the patients came from a single hospital. The criteria used to define a submassive PE was provided by the American Heart Association, and this was confirmed by a CT scan and digital subtraction angiography. The mean patient age was 55 years, plus or minus 14 years, with 67% of the patients being African American and 13% being Caucasian and 13% being Hispanic or Latino, and while 3% were of Middle Eastern descent. So the parameters measured was the time from onset of symptoms and the initiation of CDT, the systolic pulmonary arterial pressure, ICU total hospital duration, procedural and post-procedural adverse events, bleeding complications as classified by Gusto, which is a classification scale that's used to classify bleeding. Fibrinogen levels, EPA dose and frequency, and right heart function. So the dose given to each patient was at the discretion of the physician based on clinical assessment and bleeding risk, and the patients were followed until death or their last documented clinical encounter. So the primary outcomes were measured by mean cumulative administered TPA dose, mean systolic pulmonary arterial pressure, and mean follow-up intervals. Secondary outcomes included duration of ICU and total hospital stay, and pre and post procedural adverse bleeding events. The study is limited by a small sample size for the TPA dose above 48 milligrams. Mixed effects regression models were used to examine changes in pulmonary arterial pressure by increasing cumulative TPA dose over time. The KK information criteria and the Bayesian information criteria were used to select the number of random effects and the variance covariance of repeated measurements.
Okay, so as far as the results, the enrollment, there were 46 patients, 25 men, 21 women. This was a single center study. Baseline characteristics, there were 31 African American patients, which was 67%, 6 Caucasian patients, which was 13%, and 6 Hispanic or Latino patients, which was 13%, and 3% were of Middle Eastern descent. The study did not have a set number of patients between each race, nor a set number of females to males in each race. This treatment was the same through the whole study. So as far as the study of findings, this resulted of the procedure. Well, the results of the procedures were successful. Presenting symptoms resolved in 45, which was 98% of the patients, with the mean time to resolution of about 2 days. Mean ICU stay was about 5, give or take 3, and mean total hospital stay was about 8, give or take 5 days. The study includes 17 patients who were previously published in order to provide new information regarding changes in PAP and serial measurements during CDT. Upon review of the data, the prior study included 2 patients who met AHA, American Heart Association criteria for massive pulmonary embolism, including 1 patient who developed intracranial hemorrhage during thrombolysis. These patients were therefore excluded from the analysis. And so the most common and presenting symptoms were dyspnea in 42 patients, chest pain in 24 patients, and syncope in 11 patients. There were adverse events, and the first adverse event was an intraprocedural complication, which occurred in 9 patients, which was about 19%. 1 patient died 16 hours after starting CDT from cardiopulmonary arrest due to pulmonary embolism. There was mild intraprocedural bleedings in about 8 patients, which is around 18% after starting CDT. The post-procedure complications were seen in 2 patients. One patient died 22 days later of sepsis due to CDT, and the other patient developed retroperitoneal bleeding 24 hours after stopping CDT.
So just to go over some of the risk factors that patients had, obesity, 63% of the patients, hypertension, 50%, immobility within 30 days, 24%, previous venous thrombosis, thromboembolism, 20%, 15% were diabetic, 13% had recent surgery within the past 30 days, 13% had active malignancy, 7% used oral contraceptives, 4% had hypercoagulable disorder, 4% were in end-stage renal disease, and 2% had a family history of venous thrombosis. As far as the mean cumulative TPA dose, um, mean systolic artery pressure measured was 51 plus or minus 15. That's a standard deviation, and that's for the baseline. Uh, 40, 43 at 11, 11 milligrams, 41 at 27 milligrams, and 37 at 42 milligrams. So you can see, obviously, the, uh, the systolic pulmonary pressure decreased as the TPA dose increased. Um, that's that was expected, but what we're actually measuring here is the bleeding events that occur. That's what we're really looking for to see if increasing the dose also increase the amount of bleeding events.
Okay. And as far as the author's conclusion, the authors believe that their findings raise the possibility that extending the duration of CDT to administer over 24 milligrams TPA may further reduce prevalence of right heart strain in follow-up imaging. Although a minority of patients in our study underwent echocardiography or CT follow-up, these patients had similar distributions of cumulative PPA dose and systolic PAP compared to patients without imaging follow-up or appear representative of the entire cohort. In conclusion, the continuation of CDT beyond currently published trial protocols was associated with greater PAP reduction in patients with submassive PE without increase in incidence of bleeding events. I believe the author's conclusion portrays the study results based off of the levels and the charts that were presented in the study. I also think that the author viewed the results in an unbiased manner because the author discussed the shortcomings and the problems of the study and the prior studies that they had. The basis for future research was the TPA dose was not adjusted for body weight-based standardization of the TPA dose in CDT may provide more rigorous PK data, and also a control arm to see the degree of incremental PAP reduction that was attributed to additional TPA. As far as my Norman's my professional opinion, I believe the strength of the trial was aimed and more helpful to African American community, and also I believe the strength was also its weakness because the trial was not at an even number between the races in the study. I believe if you're looking for results not aimed at specific community, then this would be then the study's results are skewed and not accurate. The patients in the community that I live in is diverse, so I don't think that this study would benefit because it's not outweighing one race outweighing the other. Um, and as far as practicing, I think if a pharmacist has patients or in the community that's mainly African American, then this would be a good study to read or to start on.
Um, I think I wish the bleeding events were like how they occurred were explained more. You know, did they occur because of surgery or catheter placement? They occur because the patient was just being stuck for IV access. How did these bleeding events occur? Did the patient fall or something of that nature, and they bled out? But according to the study, there were very few bleeding events. 9 in total. You know, 8 bleeding events. 8 patients have classified mild bleeding events. One had a moderate bleeding event, and there were no bleeding events. And once again, bleeding events were classified using the Gusco scale. Um, Another problem I had was the fact that there was no set therapy. It wasn't all patients zero point 0.8 milligrams per hour for 48 hours or longer, or 24 hours or longer. It was all at the physician's discretion. So, that's a variable. We don't know exactly what dose was used and exactly how long it was used. And of course, that was all patient dependent. That is another variable that comes into play. Those physicians might have used, zero point 0.5 milligrams, and we don't know. So that's a very important question to ask. But overall, I do think the authors set out and they did prove their point. You know, uh, there was a significant reduction in pulmonary arterial pressure, and as compared to other studies, the Ultima, Seattle, and the Perfect studies, the amount of bleeding events were less for the most part, besides the ultimate study, which only had, I think, three mild bleeding events. But overall, the studies show that you can give a decreased dose over a longer period of time and achieve a certain goal. So, as far as whether or not I would use this in clinical practice, I think that is definitely patient dependent. But I do believe that this article sets the groundwork moving forward. Well, this concludes our presentation. Thank you and have a great evening.